So welcome to the second lecture on the diseases. And we're going to start with diseases found within the heart. The first one of these is endocarditis. This is an inflammation of the endocardium, or the inner lining of the heart and valves. This can be acute or subacute. Damage to heart valves or prosthetic heart valves predispose the patients to endocarditis. Can also be caused by vascular trauma or circulating immunocomplexes. Symptoms of acute endocarditis include fever, anemia, abnormal heartbeat, symptoms of a heart attack in some cases. Abdominal or side pain, Janeway lesions, or Osler's nodes have also been noted. Symptoms of subacute endocarditis are similar to those of acute endocarditis, but typically develop more slowly and are less pronounced. We can also see with subacute endocarditis an enlarged spleen, clubbed fingers and toes. And this is simply the valve edges right here of this heart that's been open, and you can actually see these nodular lesions. And these actually are damage and bacterial colonies growing on the valves themselves. So you can see how these valves would not be working very well in the functional heart. So what can cause acute endocarditis? Well, certainly staph, strep, even Neisseria, gonorrhea, or even others. Primarily subacute endocarditis is the alpha hemolytic streptococci. Most of the time, common modes of transmission for acute endocarditis are parenteral. Subacute is often endogenous transfer of normal microbiota into the bloodstream. Septicemia occurs when organisms are found in the blood and are actively growing and multiplying. Symptoms of septicemia can be systemic fever, altered mental state, shaking, chills, even GI signs. We also oftentimes will see an increased respiratory rate, respiratory alkalosis due to the increased respiratory rate, low blood pressure resulting in loss of fluid from the vasculature. So oftentimes we will see edema. Endotoxic shock is the result of a gram-negative bacteria septicemia. This is actually multiplying in the bloodstream and releasing huge amounts of endotoxins. This stimulates a massive inflammatory response mediated by cytokines. Septicemia can lead to drastic loss of blood pressure, sometimes to the point of death. Gram-positive bacteria can instigate a similar series of events where fragments of the cell wall are released into the bloodstream, but most of the time endotoxic shock is caused by gram-negative bacteria. There are a few fungi that can result in septicemia, but for the most part, septicemia is going to be a bacterial disease. And in the United States, we have somewhere around 200,000 cases of septicemia every year, and almost half of those actually will die. Now, the plague. You've probably heard of the plague. This is caused by the bacterium Yersinia pestis, and there are three manifestations in which plague can actually be seen. We can have the pneumonic plague, which is actually a primarily respiratory disease. Bubonic plague, where we see infection of Yersinia pestis in the lymph node, and this results in inflammation and necrosis, causing what is called as a bubo, hence bubonic plague. And the mortality rate of bubonic plague, even with treatment, can actually reach somewhere between 15 to 20%. Septicemic plague, this results in disseminated intravascular coagulation. We have abnormal clotting that occurs throughout the body. This results in damaged blood vessel walls, which results in subcutaneous hemorrhage and purpura that will degenerate into necrosis and oftentimes wet gangrene. Septicemic plague will actually cause 30 to 50% mortality even with treatment. So during the Middle Ages, they actually saw all three forms of Yersinia pestis presentation, but typically septicemic and bubonic plague were the ones that caused the most death. Septicemic plague is 100% mortality without treatment. And these are actually showing some buboes here on the legs, and these basically are infected lymph nodes that have become enlarged and sometimes will even erupt to the surface of the skin. And this is actually Yersinia pestis here in the bloodstream. Today, we primarily see Yersinia pestis out in the southwestern United States. And so from 1970 to 2018, you can see basically kind of clustered here in the Four Corner regions of Utah, Colorado, Arizona, and New Mexico. And so this is because this is where the prairie dogs actually live. And it's not the prairie dogs that actually carry the Yersinia pestis, but it's the fleas that the prairie dogs carry. During the plague of the Middle Ages, it was actually fleas that were found on rats. So fleas are actually the vector of Yersinia pestis. And so there are several what we call amplifying hosts. Primarily the endemic reservoir host are rodents, mice, and rats. But chipmunks and ground squirrels, groundhogs, other mammals can actually amplify this by carrying the flea, and then this can be passed on to the human. So Yersinia pestis, we've known it for a long time. Again, endemic in all of the western and southwestern United States. 95% though of all plague victims actually occur in Africa, including the island nation of Madagascar. Tularemia. This is a zoonotic disease that is endemic throughout the northern hemisphere. Symptoms of tularemia include headache, backache, systemic fever, chills, malaise, and weakness. Signs can be ulcerative skin lesions, swollen lymph glands anywhere in the body, conjunctival inflammation in the eye, sore throat, intestinal disruption resulting in vomiting and/or diarrhea, and even sometimes pulmonary involvement. Mortality rate of tularemia is around 30% without proper treatment. Tularemia is actually caused by the bacteria Francisella tularensis. This is a gram-negative facultative intracellular organism. The infective dose is fairly small, with about 10 to 50 organisms being all that will be needed to actually cause the disease. It's listed as a pathogen of concern on the Category A bioterrorism agent list. Rabbits and rodents are the chief reservoirs, and in this area, actually rabbits, wild rabbits, tend to be the primary reservoir in the Midwest. But skunks, beavers, possums, foxes, and other wild animals may also be reservoirs of Francisella. And this is just the table out of chapter 20 that talks about tularemia. Now, Lyme disease. This was first discovered in Old Lyme, Connecticut in the 1970s in the United States. It's a slow-acting, progressive disease. 70% of the cases will develop what's known as the characteristic bullseye rash around the tick bite. Symptoms can include fever, headache, stiff neck, and dizziness in the early stages, and it can progress to cardiac and even neurological signs in the late stages. Sometimes we actually will see development into crippling polyarthritis after several weeks to months. In fact, usually the primary symptoms are actually gone by that time, and so the person may not even know or realize they had Lyme disease until they get this arthritis in multiple joints. So this is the characteristic bullseye lesion. The tick bite would have been right in the center, but it doesn't always have to necessarily look exactly like that. And so these are a couple of other rashes of Lyme disease. Borrelia burgdorferi, which is a spirochete organism, has usually 3 to 10 irregularly spaced coils. It invades the immune system by changing surface antigens on the cell wall. Has multiple proteins for attachment to host cells. And it's possible that the immune response actually contributes to the pathology of the disease. It is thought perhaps that polyarthritis is actually due to an autoimmune type situation that occurs in the joints after infection with Borrelia burgdorferi. Primarily in this region of the world, the hard tick of the genus Ixodes is what's going to carry Lyme disease. So it is the vector. It actually has a 2-year cycle. In the first year, newly hatched tick larvae become infected when they feed on small animals such as the white-footed mouse that was seen primarily in the northeastern United States and the upper Midwest. They actually harbor or are the reservoir for the spirochete. The larvae will actually continue to develop then throughout the year. And the larvae tick will then actually develop into the adult tick that is also infected and will continue then to develop to the complete adult tick. So in the second year, the larva has molted into nymphs, and at this stage then, this is actually the most aggressive feeding stage. So the nymph will actually bite humans or other animals and could cause Lyme disease. The nymph will take a blood meal from a number of hosts, including deers and humans, and this will then allow them to develop into the adult male and female tick. The female will lay the eggs in plant litter where they hatch and once again begin the cycle again into the second year. The most common time that we see new infections of Lyme disease cases is actually in the fall of that first year when that nymph actually hatches out. Now, this just shows the progression of Lyme disease over several year period, and this will actually end in 2012. Sorry, 2013. Okay. But this was actually Lyme disease reported to the CDC in 2018. However, I think this is probably fairly underreported, but you can see that actually now we have a lot of sporadic cases in and around other parts of the country, and it has actually increased in the regions that they are now considered to be endemic. Missouri does have Lyme disease, and we have seen Lyme disease in southwest Missouri. There are several physicians that don't think that we do have Lyme disease in southwest Missouri, but the first case of Lyme disease I saw in a dog was actually 20 some years ago, and that dog had never left southwest Missouri. So it has been here, and we do have the Ixodes scapularis tick in southwest Missouri that is the vector in this region. So prevention is really going to be tick avoidance. Now, infectious mononucleus is caused by the Epstein-Barr virus, and this is one of the herpes viruses. It shares a lot of morphologic and antigenic features with the other herpes. There is a latency stage and the ability to splice into host cell DNA that allows it to invade the host immune response. Probably more than 90% of the world's population has actually been infected with Epstein-Barr virus. Typically, there's no way to prevent it. Epidemiologically, we see about 500 cases for every 1,000 people per year in the United States, most commonly seen in the late teens and early 20s. Bacillus anthracis, we've already talked about this with cutaneous anthrax, but Bacillus anthracis is a zoonotic disease of herbivores, and primarily for us, that means cattle. Again, we see the three forms, cutaneous, pulmonary, and the GI form of it. Bacillus anthracis is a gram-positive endospore-forming rod. It's aerobic and catalase positive. It forms a tripartite toxin, which is actually an edema factor and a protective antigen. But it may also contain, or part of it will contain, a lethal factor as well. So just a picture of Bacillus anthracis. And the most severe form of Bacillus anthracis is the inhalation form. The GI form is the least commonly seen, while cutaneous anthrax is seen fairly commonly, especially those that work in and around cattle populations. Hemorrhagic fever diseases. These are agents that infect the blood and the lymphatic system. Typically, we will see extreme fevers accompanied by internal hemorrhage. Three families of viruses will cause hemorrhagic disease, and these are viruses in the Arenoviridae family, the Filoviridae family, and the Flaviviridae family. These are all RNA enveloped viruses, and they all are classified as biosafety level number 4 pathogens. Yellow fever is one of these hemorrhagic diseases. Again, this is a single-stranded RNA flavivirus in the Flaviviridae family. Primarily, yellow fever occurs in Africa and South America along the equator because it is actually vectored by the Aedes aegypti mosquito that's found primarily in these regions. The virus actually causes capillary fragility, and this disrupts the capillary wall and actually causes hemorrhage. So again, with this damage though, we'll see fever, headache, muscle pain, oftentimes oral hemorrhage, nosebleeds, vomiting, oftentimes with bleeding, jaundice, and liver and kidney damage. And yellow fever actually has a fairly high mortality rate. There is actually a vaccine available for yellow fever and is recommended for those individuals who live in or will travel to these endemic areas. Dengue fever is a single-stranded RNA flavivirus also transmitted by the Aedes mosquitoes. It is sometimes called breakbone fever because we see severe pain in muscles and joints. This actually doesn't cause fractures, but it almost feels like that you have actually or could actually break a bone from the severe pain. This is endemic to Southeast Asia and India because, again, this particular species of Aedes mosquitoes is primarily found in that region. But we do see epidemics in South and Central America, the Caribbean, and Old Mexico. Dengue fever also carries a high rate of morbidity and mortality. Now, Ebola and Marburg are both in the family Filoviridae. Symptoms are going to be similar to yellow fever and dengue fever. The viruses both cause capillary fragility and disruption of clotting and bleeding. Patients most often bleed from any orifice and mucous membranes and experience massive internal and external hemorrhage. The mortality rate of Marburg virus is around 25%. Mortality for Ebola, however, can range anywhere from around 50 to almost 99% mortality, and that is even with treatment. The strain of Ebola that they had a few years ago in the Ebola outbreak in Western Africa was actually around 80 to 90% mortality rate. There really is no effective treatment for either disease. We simply treat these patients as symptomatically as we can. However, now that some people have actually survived Ebola, they actually do have antibodies to those viruses. And that is one way that we can actually use is intravenous immunoglobulin therapy. Lassa fever is caused by an arenavirus. The Argentine hemorrhagic fever, Bolivian hemorrhagic fever, and lymphocytic choriomeningitis are all caused by this organism. It's found primarily in West Africa, even though some cases have actually been imported into the United Kingdom. It causes a hemorrhagic syndrome. So again, hemorrhaging is going to be the telltale sign, but oftentimes these patients will also report chest pain, sore throat, back pain, vomiting, diarrhea, and this is one that actually can cause a meningitis or encephalitis. Patients who recover from Lassa fever often suffer from deafness. Disease in pregnant women leads to spontaneous abortions in almost 100% of those cases, around 95%. And this table out of chapter 20 just compares these different hemorrhagic fevers. I didn't talk about this one because it has not been reported in the United States, even though we have seen cases around the world with chikungunya virus. That's very difficult to say. Another reason I didn't talk about it. So these hemorrhagic fevers, again, we can see hemorrhage in mucous membranes from orifices. This individual is actually bleeding from the mouth and the ear. We can see hemorrhages here in the sclera, hemorrhages under the surface of the skin. This can also result, however, even in jaundice because of all of the extraneous bleeding and the breakdown of the red blood cells within the tissues where the blood has been located. Now, non-hemorrhagic fevers are diseases characterized by high fevers, but without the capillary fragility that leads to hemorrhages. And actually, all of these are going to be caused by bacteria. So, brucellosis, Q fever, cat scratch disease, trench fever, ehrlichiosis, and the Rocky Mountain spotted fevers. And we'll talk about each of these organisms here in a moment. So brucellosis, this is sometimes also known as Malta fever, undulant fever, or Bang's disease. It's actually caused by a number of Brucella organisms, Brucella abortus, Brucella melitensis, and Brucella suis. And so all of the brucellosis actually come from cattle, goats, or pigs. And all three of these can infect humans. Oftentimes the humans actually pick it up through unpasteurized dairy products, even though they've not been in contact with the animal, or they can actually simply be in direct contact with these animals. All of these are gram-negative coccobacilli. They live in phagocytic cells and carry bacteria to the bloodstream, causing focal lesions in the liver, spleen, bone marrow, and the kidneys. It is considered by the CDC as a bioterror agent of highest concern because we could infect the animal population and then actually infect the humans fairly easily. Oftentimes called undulant fever because typically we have high fevers and then they go down and then it goes back up and then it goes down, and this kind of goes on about a 10-day cycle. And I actually had a colleague of mine that had brucellosis that he got from Brucellus abortus, and he did this. He'd have a fever of 103 and feel just rotten for about 5 days, and then he'd start to feel a little bit better and his fever would go back down. He thought, okay, I'm over it. And then it would start back up. And he just did this cycling of the fever for several months, actually, even during treatment. Q fever, the Q stands for query due to the frustration in actually discovering the cause of this disease. But we now understand that this disease is caused by the bacteria Coxiella burnetii. This is a small pleomorphic gram-negative bacterium, and it's an intracellular parasite that forms an endospore-like structure. Primarily, this is transmitted with contact of infected animals, and this is primarily, again, cattle. My friend that had brucellosis also had Q fever at the same time. He was really sick, unfortunately. Now, cat scratch disease, or sometimes called cat scratch fever, is caused by the organism Bartonella hinselae. This is a small gram-negative rod, a very fastidious bacteria that will grow on blood agar as the enriched plate medium. It typically is passed to humans through infection being clawed by or bitten by a cat that has the Bartonella hinselae in the saliva. It is actually present in probably over 40% of all domesticated cats. Symptoms usually start 1 to 2 weeks after the claw or the bite, And typically we'll see a cluster of small papules at the inoculation site. The regional lymph nodes will swell and actually become infected and pus-filled. And over 1/3 of these patients will experience a high fever along with the lymphadenopathy. So here are these pustules, and this is about a week or so after probably a clawing from this individual. And this is actually one of the enlarged lymph nodes. And if we open this up, it will actually be pus-filled. Trench fever is also caused by a Bartonella species, but Bartonella quintana. This is carried by lice, and this is spread when louse feces actually enters the bite wound from the louse. Mainly this occurs in endemic regions of Europe, Africa, and Asia. Urban trench fever, 33% of homeless individuals in San Francisco, though, were found to be carrying lice that actually harbored this particular bacterium. So symptoms of trench fever, usually a 5 to 6 day period of fever. Oftentimes we'll see leg pains, headaches, chills, muscle aches, and can even see a macular rash. Endocarditis may be a sequelae of Bartonella quintana. Now let's turn our attention to ehrlichiosis. Human monocytic ehrlichiosis caused by Ehrlichia chaffanaceae. This is the most common Ehrlichia species that we see causing ehrlichiosis in humans. Human granulocytic anaplasmosis is caused by a cousin of Ehrlichia called Anaplasma phagocytophilium. Anaplasma was once actually classified as an Ehrlichia organism, but has since been reclassified. Both of these bacteria are tick-borne fever-producing diseases, and they are spread by the Ixodes genus of ticks. So, signs and symptoms of ehrlichiosis, usually an acute febrile state. In other words, you're feeling fine and all of a sudden your temperature has popped to 102. Oftentimes patients report muscle pain and headaches and sometimes even rigor within the skeletal muscle. Most patients recover fairly rapidly with no lasting effects. Typically, ehrlichiosis and anaplasmosis patients will not produce rash, but if they do, usually this is several days after the onset of the infection. And Ehrlichia chaffanaceae, ehrlichiosis, if you'll notice, we are in the bullseye of the hot zone of ehrlichiosis. However, over in Virginia, North Carolina, they also have another region that's fairly heavily endemic with ehrlichiosis, as well as up in the northern Midwest region. This is the reason for this is, again, the tick vector is found in these regions. Now, Rocky Mountain spotted fever caused by Rickettsia rickettsii mainly occurs in the southeast part of the United States and along the eastern seaboard. And yes, I know it's called Rocky Mountain spotted fever. Well, that's where it was first identified. Rickettsia rickettsii is transmitted by several species of hard ticks, all of which we do have in southwest Missouri. Rocky Mountain spotted fevers will induce chills, fever, headache, muscle pain, and typically the distinctive spotted rash will occur somewhere between 2 to 4 days after the prodromal period. If untreated, lesions of the rash will merge and actually become necrotic. Cardiovascular disruption, thrombosis, and hemorrhage can actually occur with the Rocky Mountain spotted fevers. And it carries a 20% mortality rate if untreated, 5 to 10% if we treat it. Now, ehrlichiosis, anaplasmosis, and the Rocky Mountain spotted fevers are all treated primarily with tetracyclines. Primarily right now we're using doxycycline. So this is the classic rash of the Rocky Mountain spotted fevers. And again, sometimes these will coalesce into large areas and actually result in necrosis. And we can even see the rash on the palms of the hand and the skin of the feet. This is one of several species of ticks that can transmit rickettsial diseases, and this is actually Dermacentor variabilis, which is one of the two most common species of tick that we have in southwest Missouri. And again, you can see kind of the bullseye region here is in southern Missouri, Arkansas, and Oklahoma, because is the area that we have a very high tick population. But unlike Ehrlichia and Anaplas, we can actually see that Rocky Mountain spotted fever actually can be seen pretty well throughout the entire United States. And again, because there are several different tick vectors that can carry the rickettsial organisms. And out of chapter 20, this is just simply comparing these non-hemorrhagic fever diseases. Now, let me talk a little bit about Chagas's disease. This is caused by the protozoan Trypanosoma krusei. It's a flagellated protozoan, and it's actually related to Trypanosoma brucei that causes African sleeping sickness. Signs and symptoms of Chagas's disease ranges anywhere from the acute, where we have mild to severe fever, nausea, fatigue, sometimes the chagoma at the bite site, which just basically is a swollen area where the insect vector has bitten. And this can then progress to even a chronic phase where we see inflammation, disruption in the heart, the brain, and the intestinal tract. And this is the protozoan parasite in the bloodstream. And this is actually one of several species of the Riveridae bugs that can actually pass this organism. We do have this particular organism here in southwest Missouri, but we don't see huge numbers of Chagas's disease here. This tends to be more endemic in the Central and South America, with about 300,000 cases presented each year. Now, malaria. Signs and symptoms of malaria occur in 48 to 72-hour intervals. And typically this will be malaise, fatigue, aches, nausea with or without diarrhea and vomiting, and oftentimes fever. And again, so we kind of get an undulating fever pattern here with malaria. Falciparum malaria usually results in a persistent fever, then that should say cough, and weakness for relief, or weeks without relief. Cerebral malaria, small blood vessels in the brain become obstructed by the organisms in the red blood cells. And so the Plasmodium genus is the organism that is the causative agent of malaria. And these are apicomplexans, which are basically non-motile protozoans that live in animal hosts and lack the locomotive appendages in the mature states. The asexual phase is actually carried out in the human red blood cell. The sexual phase of the Plasmodium organisms is carried out in the Anopheles species of the mosquito. Genera include Plasmodium malariae, Vivax, Falciparum, and Ovale, and Knowlesi. The malarial organism in the red blood cell will form this kind of ring-like structure. And this is actually the asexual stage of the malaria protozoan. And so when we see these ringed, we sometimes refer to them as the signet ring sign in the red blood cells. This is malaria. So when the female mosquito bites and takes the blood meal, the sporocyte will actually be injected into the bloodstream of the human. There, it will actually then infect the red blood cell and develop into the merocyte. This will then rupture the red blood cells, and this is what will then can cause damage. But the ring trophocyte will actually undergo reproduction. And if we wind up with gametes, which then will be transmitted to another mosquito in another bite. And then those gametes will develop into the sporocyte. And when she goes to bite someone else, this is the way that we transmit malaria. The invasion of the merocytes into the red blood cell then causes the release of fever-inducing chemicals into the bloodstream. And Plasmodium actually metabolizes glucose at a very high rate. Damage to these red blood cells then results in anemia, an accumulation of malarial products in the liver, and immune stimulation in the spleen can actually lead to hepatomegalia and splenomegalia. Parasites will undergo antigenic variation. And so just because you've had one type of malaria does not necessarily mean you cannot get it again. Transmitted by the female Anopheles mosquitoes, and so it's restricted basically to the tropical regions of the world. 3 million new cases of malaria are reported every year, and 90% of those are in Africa and India. Over 1 million deaths occur annually from malaria. It is estimated that every minute one person in the world dies from malaria. So you can see that basically the endemic regions, this is the equator right here. So Northern South America, equatorial sub-Saharan Africa, India, southern Asia, and some of the island nations. We've even seen some malaria up in Central America, a few cases in Mexico, but so far we've not seen any naturally transmitted malaria in the United States, even though we have seen some Anopheles mosquitoes in the southern U.S. Prevention, really controlling the vector. Okay, so eliminating standing water, spraying insecticides to kill the mosquitoes, to release sterile males, mosquitoes, so that the females do not reproduce. Mosquito netting is one of the easiest and cheapest ways to actually prevent malaria. Human chemoprophylaxis, basically using prophylactic treatment for travelers into endemic areas. So the use of primaquine going to these areas. I actually had a friend that went to Vietnam on vacation several years ago, and he came back with a friend. And I asked him, "Did you not take your primaquine every day?" And he goes, "Well, I took it most days." It's kind of like taking birth control most days. It just didn't work, and he wound up actually with malaria. People with a history of malaria are forever excluded from blood donation. A vaccine for the organism has reached clinical trials, but I have not heard of anything about it in the last little while. Treatment chloroquine, which is a form of quinine, has really become ineffective due to resistance because we have used it for so many years against malaria. So the mefloquine or primethamine plus sulfadiazine has been used pretty effectively in the last few years. Uh, Artemisinin is also another one that's been used. I don't know a lot about that one. Counterfeit malarial drugs sold in Southeast Asia probably have contributed overall to resistance of the malaria protozoan. And again, here's one of the cheapest and probably most effective ways to actually prevent malarial diseases, and that is just simply to stop the mosquito from getting to a potential host. So this is the table out of chapter 20. All right, let's talk about HIV. Human immunodeficiency virus. This was first isolated in the early 1980s. It is a retrovirus in the Retroviridae family, and it causes acquired immune deficiency syndrome, or AIDS. There is a complex of symptoms with this virus. People with HIV do not die from HIV. They die from other diseases that the immune system that is now so compromised by the HIV infection cannot overcome. So, pneumonias, and 50% of all AIDS patients die of simple pneumonias, most often caused by pneumocystis jirovecii, which is an actual known microbiome yeast found in the normal lung. Kaposi sarcoma. 25% of AIDS patients will develop this very, very rare cancer of the skin. Sudden weight loss, swollen lymph nodes, general loss of immune function. So signs and symptoms is tied to the level of virus in the blood and the level to which T helper cells are infected. The primary and preferred host of HIV is the T helper cell. Initial symptoms kind of flu-like: fatigue, diarrhea, a little weight loss, some neurologic changes. And then oftentimes we see opportunistic infections. But as the disease progresses and the infection becomes more severe, we get fewer and fewer T helper cells, and this results in severe immune deregulation, hormone imbalances, and metabolic disturbances. This results in weight loss, diarrhea, poor nutrient absorption, can lead to protracted fever, sore throat, night sweats. Even lesions on the brain, meninges, spinal cord, and the peripheral nerve have been seen in AIDS patients. Now, this may take years for AIDS to actually show up. And this graph just simply shows the initial infection is most often attended by vague mononucleus or flu-like symptoms that soon disappear. This phase corresponds to the initial high levels of the virus, which is the green line here, and the yellow line is just showing the progression of or the level of antibodies. The purple line is the level of T helper CD4 cells. In the second phase, the virus number in the blood actually drops, and this reason for this is actually that now they have infected the cells, not because they've been cleared out by the immune system, and antibodies begin to appear. Well, this is about right. Again, this 2-week period, a little longer than the normal 5 to 10 days of the normal primary immune response, but this is actually still a primary immune response. Part of the problem, though, is that these viruses infect T helper cells so quickly that the immune system really doesn't get a chance to look at them very fast. And so what we'll start to see is somewhere in this area, the CD4 T helper cells begin to decrease in number. As we go along in the variability, mostly the individual is going to be asymptomatic. And this can last anywhere from 2 to 15 years, sometimes as long as 30 years. During the mid to late asymptomatic period, the number of T cells in the blood is steadily decreasing, though still functional. Once the T level reaches, though, a low threshold, that is when the symptoms of AIDS ensues. And the definitive accepted line of this is when you get below 200 T helper cells per milliliter of blood is when AIDS will actually begin to be seen at that point. Once we drop below that level, AIDS results. And note, even though antibody levels remain high, virus levels in the blood begin to rise. Here's the reason why. HIV is a retrovirus. The retrovirus carries reverse transcriptase. Once inside the T helper cell, the reverse transcriptase will make a complementary DNA strand, double strand, of the viral RNA. This then will actually be incorporated and spliced into that cell's genetic code, where it remains unread for, again, this latent period of 2 to 30 years. Then all of a sudden, we start reading the viral code and making huge amounts of the virus and releasing them by lysing the T helper cell. So that's the reason that the levels start dropping precipitously of the T cells and the viral count actually starts increasing. The causative agent is in the genus lentivirus of viruses in the Retroviridae family. Lenti means slow, and so this is a slow progressing disease. Again, HIV contains that reverse transcriptase that catalyzes the replication of a double-stranded DNA from the single-stranded RNA of the virus. The viral genes, as that double-stranded DNA, then become permanently integrated into the host cell's own genome. There are actually two strains of HIV seen. HIV-1 is the most dominant form that we see in the world, and HIV-2. Subtypes of both of these actually exist, and so in one individual, we may actually have 20 to 40 different subtype strains of each one of these. HIV has been studied extensively, and we know that there are a number of certain envelope proteins that are necessary for attachment to the T helper cell. And one of these is the GP120 protein. This, along with some other ones, actually will attach to the CD4 receptor on the white blood cell. And so these GP120 proteins are what's responsible for attachment to the host cell. So we see docking and fusion of the GP120 with the CD4 receptor. That will cause then uncoating of this RNA carrying virus, and the single RNA is released into the cytoplasm, where the reverse transcriptase that the virus carries with it will simply make a single-stranded DNA and then come back and make the double-stranded DNA. That completed double-stranded DNA then is spliced into the host cell's genome, where again it may sit like a ticking time bomb. Then after a period of time, and we're not sure what will trigger this, but we begin to read that viral code. We will then make messenger RNA that's going to make the viral proteins of HIV, and of course the messenger RNA as a single strand can actually then be used as the genetic code of a new virus. We then will assemble the virus, and this will actually then bud, and so it will pick up the outer cell membrane of the host cell as its cell or as its envelope. And in fact, the viron does not even have to completely be loosened from its original host cell. It could, even as it's budding, attach to another susceptible host cell and actually go straight from this cell into the next susceptible cell. Transmission of HIV, any form of intimate contact involving transfer of blood or other body fluids, could be a potential source of infection. So, sexual transmission, breast milk, but urine, tears, sweat, and saliva are not considered sources of infection, even though there have been HIV viruses found in these body secretions. They have never shown to be infective to another host. So, direct blood exposure through shared needles, blood exposure during sexual intercourse or other intimate contact, and even semen, vaginal fluid also can contain enough of the virus to be transmittable. Epidemiology of HIV. Since the beginning of the epidemic in the 1980s, 60 million cases have become infected and 30 million have died of HIV-related causes worldwide. The global estimate Currently, incident rate is about 34 million worldwide, with about 1.1 million infections currently in the United States. 2.5 million new cases occurred worldwide just in the year 2011. And this table out of Chapter 20 shows the infection in the United States by exposure category. Culture and diagnosis. A person is diagnosed as having HIV infection if they have tested positive for exposure to the human immunodeficiency virus. This diagnosis is not the same as being diagnosed with AIDS. Viral testing is based on detection of antibodies specific to the virus in serum or other body fluids. And we have an ELISA test for this, a latex agglutination test, and a rapid antibody test. A diagnosis of AIDS is based on two criteria. First, testing positive for HIV, and the fulfillment of one of the following criteria. A CD4 count or a T helper cell count of fewer than 200 T helper cells per microliter of blood, or CD4 counts account for fewer than 14% of all lymphocytes. Or if the person is experiencing one or more of the CDC provided list of AIDS-defining illnesses. Prevention, avoidance of sexual contact with infected persons. Barrier protection should be used when having sex with anyone whose HIV status is unknown. Not sharing needles or by cleaning needles with bleach and then rinsing before another use. HIV positive individuals with uninfected partners should begin a regimen of antiretroviral drugs. 30 potential HIV vaccines are currently in clinical trials, but so far none of them have shown good enough efficacy to actually use in humans. Treatment should begin as soon after HIV diagnosis is made. Antiretroviral chemotherapy and a variety of drugs to prevent or treat opportunistic infections or other AIDS-defining infections. Strabilda is a quad pill. It contains 2 reverse transcriptase inhibitors, 1 integrase inhibitor, and a drug that actually inhibits liver enzymes from breaking down the other drugs. So again, what if we were to put in to this cell something that actually blocked the reverse transcriptase? And these drugs, such as AZT and others in the same class, are actually nucleotide analogs. And what they do is they mimic the structure of the nucleic acids, and they actually then will stop DNA synthesis from the viral RNA. Or we can actually use protease inhibitors that will stop the creation of proteins within those cells. And so this would include actually making then of viral proteins. We actually can use integrase inhibitors, and what this will do is HIV also carries an enzyme called integrase. What that does is it will take the double-stranded DNA and cut the host cell's genome in order to put the viral genome in. So these integrase inhibitors actually will block this integrase, and so if we are not able to splice in the viral code, then we wind up not being able to read it. So again, out of Chapter 20, this is just the table looking at HIV. So summing up, the microorganisms that cause disease in the cardiovascular and lymphatic system. And again, this is all out of Chapter 20. Page numbers may not match exactly. Now, the good old common cold. In the United States, people suffer from 67 million colds per year. $40 billion every year is spent in medical costs, and the 22 million missed days of work are associated with the common cold. Signs and symptoms: sneezing, scratchy throat, runny nose, generally not accompanied by a fever, even though sometimes low-grade fevers can occur. And the infection can predispose patients to secondary, oftentimes opportunistic infections. There are over 20 different kinds of viruses that cause the common cold. 99 serotypes of rhinoviruses, coronaviruses, and adenoviruses cause colds. Symptoms are usually due to the immune response to the virus, not any particular virulence factor. These viruses are commonly transmitted through droplet contact and indirect transmission on fomites. There is no vaccine, there's no specific chemotherapeutic agent, there's no real good antiviral out there, and so basically you just have to suffer through it. So prevention, really, hygiene practices: wash your hands, don't touch stair railings, elevator buttons, vending machine buttons, uh, just stay away from people that are sneezing and snotting around, all of those things that we're already doing at the moment. Sinusitis, inflammation of the sinuses. Well, certainly viruses can cause that. Bacteria can, and most often these are actually normal microbiomes. Pathogenesis usually occurs due to an underlying viral infection, and this causes buildup of fluids, which then provide a rich bacterial media and the anatomy of the sinuses that can actually entrap the bacteria and the mucus. That's why a lot of times with colds we get secondary bacterial infections. Fungi sinusitis is rare but recognized when antibacterial drugs oftentimes fail to alleviate the bacterial sinusitis. So again, a number of viruses, several bacteria oftentimes are mixed, and oftentimes these are actually opportunistic organisms and various fungi. These can be introduced by trauma or water even, or by, again, opportunistic overgrowth. Pharyngitis, and this is basically the sore throat. Inflammation of the throat causing pain and swelling. Inflammatory packets are visible on the wall of the throat, and this can actually result in difficulty in swallowing, foul breath, sometimes even difficulty in breathing. And these inflammatory packets are primarily the tonsils. Viral pharyngitis is typically fairly mild and may lead to hoarseness or even your loss of voice. Bacterial pharyngitis tends to be more painful, often accompanied by fever, headache, and nausea. And so this is an individual that still has their lovely little pharyngeal tonsils back there. And so they're nice and swollen. We can actually kind of see this discoloration that is actually pus on the surface of the tonsils. Certainly we see a lot of erythema throughout the entire pharyngeal region. I had my tonsils removed when I was 7, and I actually lost 2 pounds. And they removed them primarily because we also have a set of tonsils just above the soft palate up in the nasopharynx called the adenoids. And my adenoids especially were so swollen that they were cutting off my the flow of air from the nasal sinuses down into the laryngopharynx. And so they took out my pharyngeal tonsils and adenoids. We do have a third set, the lingual tonsils on the base of the tongue, way back there. Those are not removed in a tonsillectomy. Now, what can cause pharyngitis? Well, one of the most common bacterial uh, causes is Streptococcus pyogenes, that gram-positive cocci. Uh, Untreated streptococcal infections can result in very serious sequelae, including scarlet fever and rheumatic fever, and even glomerulonephritis in the kidney. Also may result in necrotizing fasciitis because Streptococcus pyogenes is the causative agent of the flesh-eating bacterial disease called necrotizing fasciitis. Streptococcus pyogenes has a number of virulence factors, and these are surface antigens of Streptococcus pyogenes that mimic some host proteins. And this is why sometimes then we get these sequelae. Surface antigens protect the organism from being affected by the lysosomes found in the mucus and saliva, and streptolysin O and streptolysin S produced by strep pyogenes can actually injure cell and tissues. Erythrogenic toxin produced by lysogenized strains of S. pyrogens can actually cause the disruption of the erythrocytes. And some streptococcal toxins actually act as superantigens. So this is actually one of these strep pyogenes organisms. And again, they have a number of different antigenic structures on their cell wall. The M protein, the peptidoglycan can actually act as one of these, and they have a hyaluronic acid capsule. And this is what keeps them basically from being seen by the immune system. We also see a number of viruses that can cause pharyngitis, and Fusobacterium necrophorum is another one that can cause pharyngitis. Usually this is actually an opportunistic organism. And this table is out of chapter 21. Now, diphtheria. Diphtheria has caused significant morbidity and mortality for hundreds of years. We do now have a very effective immunization protocol with the diphtheria toxoid that has caused the number of cases to decline significantly, especially in industrialized regions of the world. Epidemics of diphtheria and smaller outbreaks have occurred due to a breakdown in immunity, primarily due to lack of vaccinations. And the causative agent of diphtheria is Corynebacterium diphtheriae. This is a non-endospore-forming, gram-positive, club-shaped bacterium. Those are not endospores. That's actually just part of the vegetative cell. This produces sore throat, lack of appetite, and typically a low-grade fever. One of the classic clinical signs of diphtheria is the formation of what's called the pseudomembrane. And this forms on the surface of the tonsil or pharynx and can actually completely block respiration. The DTaP vaccine is recommended for children with the DTaP booster for individuals 11 to 64 years of age. So most of the time you're getting a DTaP because of the tetanus booster every 10 years, and that just simply gives you also a booster for Corynebacterium diphtheriae. And this is that pseudomembrane. It's kind of a hard, thickened mass of mucus and just kind of yuck. And again, this could actually completely block the naso and oropharyngeal region. And this table's out of chapter 21. Now, whooping cough. The catarrhal phase is when the bacteria in the respiratory tract causes cold-like symptoms. The paroxysmal phase is the uncontrollable cough accompanied by a whoop sound. Oftentimes, we can actually make a diagnosis of whooping cough simply by hearing the individual cough. This coughing can actually result in broken blood vessels in the eye. It can cause vomiting or even hemorrhages in the brain. These coughing episodes can just be so severe and so dramatic that we can actually break blood vessels. The convalescent phase of whooping cough, bacteria are decreasing, but the ciliated epithelium have been damaged in the tracheobronchial tree, and this may require weeks to months of recovery. Whooping cough in humans is caused by Bordetella pertussis. This is a small gram-negative rod, strictly aerobic and fastidious. It produces a filamentous hemagglutinin, which is essential for attachment of the Bordetella to the epithelial surfaces, where it then produces a pertussis toxin that causes massive mucus production, and a tracheal cytotoxin that causes direct destruction of the ciliated epithelial cells. So we accumulate all of this mucus in the tracheobronchial tree and in the pharynx, and that results then in the severe coughing. There is another form of this that we see actually in dogs called kennel cough, and it's also caused by a Bordetella uh, organism, and I usually can make that diagnosis just by hearing the puppy coughing out in the waiting area, because they'll be going and it's like, yep, that sounds like kennel cough. For humans, there is a pertussis vaccine, and the high vaccination rate has actually kept incidence of whooping cough down. However, we are seeing breaks in our vaccination protocols, and we are seeing an increase in whooping cough. The vaccine does not provide lifelong immunity, and so boosters are necessary. We actually have seen increasing incidence of whooping cough in adult patients, and again, this is usually due to the lack of boostering of the vaccine. Disease can easily be passed to infants who are not yet fully immunized, and that's why anybody that's going to be around a newborn, it is highly recommended that they get a pertussis vaccine. The organism may be evolving, and the current vaccine may not provide the best protection against some new strains that we may actually be seeing causing the increased numbers of this disease in the United States. And of course, the rise of unvaccinated individuals. So we have seen a decrease over the years due to the DTaP and the pertussis vaccine coming out. But again, we've seen these little peaks here recently. And is this just simply that we have had breaks in our vaccine protocol, or is it due to new strains, or a combination thereof? And so this table is in chapter 21. Now, let's talk about our good old flu virus, influenza. Okay, why do we want to study the flu? Well, annual flu seasons have the potential for turning deadly for many people very, very quickly. Many diseases are actually erroneously termed the flu. I mean, simple colds can actually be called flu as well. Behavior of influenza viruses illustrates how viruses can and do cause more serious diseases than they did previously. Signs and symptoms of influenza can include headache, chills, a dry, hacking cough oftentimes, body ache, fever, stuffy nose, oftentimes with very little discharge, and sore throat. Extreme fatigue that can last for a few days to even weeks. And there are numerous strains of influenza viruses. I think we are now up into the 160s for different strains of influenza virus. H1N1, the swine flu, not all patients had a fever with this, but many patients had gastrointestinal distress and actually developed multi-organ system failure. And this was the swine flu that outbroke in 2009. So, influenza, it's a negative sense RNA carrying virus. It does produce a hemagglutinin and a neuraminidase, and it is an enveloped virus. The hemagglutinin has agglutinating actions on the red blood cells, binds to host cell receptors of the respiratory mucosa. The neuraminidase breaks down protective mucus coating of the respiratory tract, and again, to allow for adhesion of the influenza virus. And this may also assist in viral budding and release of the virus from the epithelial cells. It keeps the viruses from actually sticking together to each other and participates in the host cell fusion. Now, one of the big reasons why we have studied influenza viruses so much is because they do have the propensity to change their genetics so quickly. And they can do one of two things. Antigenic drift is a gradual change of the amino acid composition of influenza antigens. And this is due to usually point mutations within the genetic code. Each time, though, we change the composition of the influenza antigen, that means now the immune system has to go back and start over with a primary immune response because it has no memory to this now, quote, new antigen. Now, antigenic shift is more dramatic, and this oftentimes results in the viruses that can become more deadly. This is actually a swapping out of one of the strands of viral RNA with a gene or strand from another virus. And so there is no recognition whatsoever of the host memory cells because we've never seen anything that looks like this. I mean, with the antigenic drift, we go, yeah, it's probably an influenza antigen, but we've not made specific antibodies to that. We might have it might fit a little bit with the antibody, and we're going to have a weak response. With the antigenic shift, we've never seen anything like this. We have to start completely at stage 1 with antigen presentation. So, antigenic shift oftentimes results in the influenza pandemics that we've seen. So this is just showing, again, antigenic drift. So we have this complement of antigens here on the envelope. A point mutation actually has occurred, and now we get a different complement. So this guy is no longer this guy, but it's something else. Okay, or these have moved in position or whatever. So this, again, is usually not real dramatic. This is. The shift, however, will take part of the RNA from this strain and part from this guy and oftentimes reassort them in a carrier, either poultry, birds, or swine, and now we come up with a completely novel new strain of this particular influenza virus. So, for example, down here, these two, avian H3N8 and H2N2, so bird flu and the human flu, were genetically reassorted in the swine to come up then with the human H3N2 virus. So how do we prevent influenza? Wash your hands, wash your hands, wash your hands with soap and water. Okay. A standard vaccine has variable effectiveness. Consists of usually 3 or maybe 4, depending on the year, different inactivated influenza strains that are updated annually. And these are the 3 or 4 most common strains that were seen in the previous flu season. Flu Mist, which is the intranasal vaccine, contains 3 live attenuated strains. And scientists are continually researching emerging strains in an attempt to prevent a pandemic. So oftentimes when we get a really bad influenza season, it's because our best guess from the last season strains that made it into the vaccine for this year's flu season is not the strain that we're seeing now this year. And so that can be a real problem. And in fact, in 2012, the CDC actually reported that in one of our target populations for the influenza vaccine, those 65 and older, there was only a 9% efficacy rate in that particular season's vaccine. That means that only 9 out of every 100 of those 65 and older actually got protection that year from the strains that were seen that year in that flu season in 2012-13. That's why we now have a vaccine that is a stronger vaccine that we actually give to 65 years and older. So the most common causative organisms, influenza A, B, and C, and then again, there's a whole bunch of subtype and substrains within each of those. For seasonal flu, deaths vary from year to year. In the United States, it ranges anywhere from 17 to 52,000 per year, and internationally, anywhere from 250 to 500,000 every year. Now, tuberculosis. This is actually also a very ancient human disease. We've known about it for a long, long time. It's actually been found in mummies from the Stone Age, in ancient Egypt, and even in mummies from Peru. Prevalent cause of disease historically, captain of the men of death or the white plague is what it was called. Streptomycin has actually reduced rates significantly of tuberculosis, but in the last several years, maybe about the last 8 to 10, we have seen a significant rise of TB. So now it is considered a re-emerging disease. Some of this may be due to the HIV epidemic because many HIV patients actually developed concurrent infections with Mycobacterium tuberculosis. Could be due to drug-resistant strains, of which there are several, and probably 1/3 of the world's population is actually infected. Primary tuberculosis, the infective dosage only has to be about 10 bacteria. Bacteria are actually phagocytized by macrophages in the alveoli, but they resist then the phagolysosome formation, and so they just simply continue to grow inside the alveolar macrophages. These can then form tubercles, and these are granulomas, these chronically walled off inflamed areas that contain a core of the TB bacteria and enlarged macrophages surrounded by an outer wall of connective tissue made by fibroblasts, and inside these granulomas will be numerous lymphocytes and macrophages. These can actually get to a size where they become necrotic and actually form caseous exudate. And so when you cut these granulomas off, and oftentimes it kind of looks like cottage cheese. As the cells are dying from the necrosis, the lesions actually can become calcified, and so they can actually become almost rock-like. Secondary or reactivation tuberculosis, the bacteria can remain dormant in the lungs for weeks, months, or even years. And then they can become reactivated when immunity wanes for some reason. Severe symptoms of reactivation tuberculosis include violent coughing, greenish or bloody sputum, low-grade fever, oftentimes anorexia with weight loss, fatigue, night sweats, and chest pains. And in the older term, the reactive tuberculosis was often referred to as consumption. So on a lot of death certificates from even the 1800s into the early 1900s, sometimes the cause of death was simply listed as consumption. Untreated reactivated tuberculosis has a 60% mortality rate. Now, extrapulmonary tuberculosis. The organs that are most commonly involved will be regional lymph nodes, the intestines, kidneys, long bones, genital tract, brain, and the meninges. Mycobacterium tuberculosis is a long, thin, acid-fast bacterium. It is a strict aerobe. And so again, if I'm thinking that my patient could have TB, I would probably request a acid-fast stain on the sputum. And so if I see the red organisms that take up that carbofusion stain of the acid-fast bacterium, I pretty much already have my diagnosis. Generation time is about 15 to 20 hours. It takes about 6 weeks for colonies to actually appear on media. So this is a slow grower. It produces cord factor, which is a lipid component in the mycobacterial cell wall associated with the virulent strains of tuberculosis. And this includes mycolic acid and waxes, which actually make this the acid-fast bacteria. So it makes the organism resistant to drying agents and to disinfectants. Transmission of tuberculosis is through fine droplets of respiratory mucus that is suspended in air. Epidemiological patterns vary with the living conditions of a community or the area of the world that we're looking. Tuberculosis is most often found in cloistered populations like prisons, nursing homes, college dormitories. But oftentimes we think TB is an infection of poverty. Inadequate nutrition, debilitation of the immune system because oftentimes of the inadequate nutrition, poor access to medical care, lung damage oftentimes due to tobacco and or other drug usage, and certainly crowding. And then, of course, genetics also plays a role. Diagnosis, many of us, since we have been in the healthcare industry, have had the Manitou test. And this shows evidence of delayed hypersensitivity reaction after initial infection with TB. We have a purified protein derivative that is injected just under the skin intradermally and is observed for evidence of induration, indicating delayed hypersensitivity. This induration is basically a wheal and flare or inflammation. We can also use the interferon gamma release assays, which is a blood test, to determine T cell reactivity to Mycobacterium tuberculosis. We can do an acid-fast staining of a sputum sample. And we now have, of course, PCR methods. Chest x-rays or chest radiographs often verify the presence of tubercular granulomas when other tests give intermediate results. So the Manitou test, we simply inject this purified protein into the dermis of the skin, so just under the epithelium, and then we read it in 48 to 72 hours. And the size of induration then will determine whether or not we've had exposure. And so in this case, it's 20 millimeters, and so this would indicate that this individual's had exposure. Doesn't mean they necessarily have tuberculosis, but they've had exposure. And in looking at this chest film, we actually can see, and hopefully you can kind of follow my green pointer here, but you can almost kind of see that there's a denser ring right around here, and this is actually a granuloma. And you'll notice it's kind of lighter in the center, and this is actually because this is probably filled with caseous necrosis. And this is also probably a smaller granuloma lesion down here. Treatment for active tuberculosis, we have a number of drugs that we still use, rifampin, isoniazid, and ethambutol. At 4 to 7 months, we just simply use rifampin and isoniazid. With latent tuberculosis, again, same drugs with rifampicin being added. Patient noncompliance oftentimes leads to drug-resistant strains. We have to treat tuberculosis for months, and so people just stop taking their medication oftentimes. And so we wind up with these drug-resistant strains, and these are just a couple of those. So tuberculosis. Now, you'll see the white areas here in Africa. This doesn't mean they don't have tuberculosis. It's just that no data is available. These are typically very poor countries, and so I'm sure that tuberculosis is present. It's just probably that there's no data that we can find. We can see that we have some high areas, such over here in China, in the Middle East, that have significant cases, and up here in actually in Europe, Eastern Russia, we actually also have quite a number of cases. So this just compares Mycobacterium tuberculosis to actually one of the other mycobacterium called Mycobacterium avium or inticellare. These actually are primarily found in birds and transmitted to humans from birds. And these are problems oftentimes in AIDS patients. Now, pneumonia. What is pneumonia? Well, it is inflammation in the lungs which causes fluids to fill the alveoli. That's caused by a wide variety of microorganisms, both viral, fungal, and bacterial. These organisms that cause pneumonia have to avoid phagocytosis by the alveolar phagocytes, or at least avoid destruction within the phagocyte. Viral pneumonia is usually, but not always, milder than bacterial pneumonia. And fungi can cause pneumonia as well. In fact, we actually have some resident fungi that can result in pneumonia under immune compromising situations. Signs and symptoms. Oftentimes pneumonia begins with upper respiratory signs. So runny nose, congestion of the sinuses, headache, fever. But the lung symptoms, chest pain, fever, cough, and sometimes severe coughing, and production of discolored sputum, either green or actually blood-streaked. Patients with pneumonia often appear pale and sickly due to the pain and difficulty in breathing. I mean, think about it. Your alveoli are filled with fluid. You can't get good oxygen exchange. Literally, pneumonia kills you by internal drowning within the alveolar space. Severity and speed of onset of symptoms depends on what the etiological agent actually is. So again, we produce huge amounts of exudate, and that's this liquid that's filling the alveolar spaces. So we can't move air into the alveoli, or if we can get it down into the alveolar sacs, oftentimes the alveoli themselves are just completely filled in with fluid. We can see things like lobar pneumonia, is this case where only the right lower lobe of the lung is being affected, and we can see what we call consolidation. So it appears more white because of the fluid. Or we could actually just see a generalized pneumonia where all the lung lobes are actually affected. Community-acquired pneumonias oftentimes are the result of streptococcus pneumonia that accounts for about 40% of all community-acquired pneumonias, and another 30% are viral in origin. Mycoplasma pneumoniae, which is the walking pneumonia causing the atypical pneumonia, will cause another 20%. And then the other 10% are caused by other bacteria or fungi. And these can include things like Legionella, Haemophilus influenza, Histoplasma capsulatum, hantavirus. Streptococcus pneumoniae, small gram-positive flattened cocci that actually usually appear in pairs, but they can appear in chains, hence the name strepto. They're part of the normal microbiome of the respiratory tract, but usually in small numbers. Infection usually occurs when strep pneumoniae is inhaled into deep areas within the lungs, down into the alveoli. So factors that enhance strep pneumoniae can include simply old age, seasonal conditions, underlying viral respiratory diseases, diabetes, chronic abuse of alcohol or narcotics, or some other immune compromising disease such as HIV. Mycoplasma pneumoniae. This is this atypical or sometimes referred to as walking pneumonia. Symptoms of this pneumonia do not resemble those of the pneumococcal or other pneumonias. The cells themselves are the only bacteria that lack the cell wall. And so oftentimes when especially grown in culture, they take on these very pleomorphic spindle cell shaped irregular shapes. Mycoplasma is transmitted by aerosol droplets among individuals usually living in close quarters with others. So again, prisons, long-term health care facilities, college dorms. And so sometimes referred to walking pneumonia because oftentimes these folks don't get a severe fever, they don't feel all that bad, and they keep walking, if you will. Diagnosis really is through ruling out other causes or PCR testing or serological analysis to see what type of organism is causing this pneumonia. Legionella pneumophilia. This is a fairly recently recognized bacteria. It's a weakly gram-negative rod-shaped bacteria. It can display a variety of shapes, however. It was first discovered in a group of individuals up in Connecticut during a 1976 American Legion convention, hence the moniker Legionella. We do now know that this is actually widely distributed, however, in aqueous environments. So tap water, cooling towers, which is where they found the original Legionella organism in the cooling towers of the air handling system of this hotel that the convention was in, spas, ponds, other fresh water. And so really Legionella typically is more of an opportunistic disease. It affects primarily individuals with immune compromised situations, so elderly individuals, AIDS patients, rarely seen in healthy adults and children. However, when we first discovered this, we did have some middle-aged and even younger individuals that came down with this type pneumonia when we discovered this in 1976. Histoplasma capsulatum is one of our systemic uh, fungi diseases. It's also referred to as Darling's disease, Ohio Valley fever, or spelunker's disease. And the spelunker, those are individuals that go into caves. And so sometimes also known as caver's disease. It's a dimorphous fungi. It actually will be mold-like at room temperature and form a yeast structure that kind of has these little weird spikes on it at body temperature. Can be benign or very severe. It can cause acute disease or result in chronic disease. Most severe forms of histoplasma pneumonia actually occur in AIDS patients. Chronic pulmonary histoplasmosis, the signs are actually similar to tuberculosis in the fact that we can actually see walled-off granulomas. This is endemic to all continents except Australia, and where it tends to be concentrated in the United States is in the Ohio and Mississippi River valleys. And this is most associated with bird droppings and bat guano, hence the spelunker's or caver's disease. So the birds and the bats actually shed the organism in their feces. The feces dries, then will be aerosolized, and we breathe it in. I actually treated a dog several years ago with histoplasma pneumonia, and the dog came in and was coughing. Well, what can cause cough in a dog? Lots of things. And what we actually saw was, as I was starting to go down my rule out list of what can cause coughing in a German Shepherd, the client said, well, could my dog have histoplasmosis? And I was like, what? Because that's not usually a word that just rolls off the tongues of my clients. And I said, you're a caver, aren't you? And she goes, yep. I said, you took the dog in the cave. Yep. I said, how did you know? She goes, I'm on ketoconazole because I have histoplasmosis. So both she and the dog were on ketoconazole, one of our antifungal drugs, for actually several months. I think the dog was on it for 6 months and she was on it for 8 months. So high prevalence in Ohio, Illinois, Missouri, Kentucky, Tennessee, Michigan, even Georgia and Arkansas. So out of chapter 21, this actually just compares the community-acquired pneumonia. I didn't mention Pneumocystis jirovecii. This is one of our normal microbiome fungi that we see, and typically the only time we see Pneumocystis pneumonia is actually in AIDS patients. Now, healthcare-associated pneumonia. This actually accounts for several people that develop pneumonia in hospitalized. So about 1% of all hospitalized or institutionalized people will develop a healthcare associated pneumonia. Most often this is associated with mechanical ventilation via endotracheal or tracheostomy tubes. These pneumonias oftentimes carry a 30 to 50% mortality rate, and one of the reasons is because most of the time these individuals are already immune compromised. They're in the hospital for something else. They're older in a nursing care facility. Causative agents can be Pseudomonas aeruginosa, Acinetobacter baumannii, Streptococcus pneumoniae, Klebsiella pneumoniae, Staphylococcus aureus, and usually this is MRSA or VRSA. Most cases are actually polymicrobial in origin. So, how do we prevent these healthcare associated pneumonias? Well, most are caused due to aspiration from the upper respiratory tract down into the lungs. So elevating the patient's head 45 degrees helps to reduce the aspiration of the secretions in the higher tracheobronchial tree. Deep breathing, frequent coughing, and that's oftentimes when patients have come out of surgery, what they want you to do is sit up and cough to try to get some of that stuff that you may have gotten down into the lower airways back out. Proper care of ventilation and respiratory equipment, and empiric antibiotic therapy should be started as soon as healthcare associated pneumonia is actually suspected. So again, a number of different organisms can actually cause this. One thing that we sometimes will see is something called aspiration pneumonia, and this can actually be when we get stomach content that is actually aspirated down into the lungs, that then can cause some of the opportunistic pneumonias that we see. Now, I want to mention hantavirus because this is a very serious disease. Hantavirus pulmonary syndrome. The first cases in the United States were actually a cluster of patients seen in the Four Corners area of New Mexico in 1993. Most of these patients were young, healthy adults, and they died with only a few days of the onset of signs and symptoms. We then identified hantavirus, and this was an agent previously only been known to cause severe kidney damage and hemorrhagic fevers in other parts of the world. This emerging disease has a 33 to 50% mortality rate, even with treatment. The signs and symptoms, the prodromal phase is often fevers, chills, myalgias, headache, nausea, vomiting, diarrhea. Again, kind of those, we don't really know what might be causing this signs. Cough is common, but not predominant in the early stages. However, within a very short period of time, and I'm talking 6 to 24 hours, severe pulmonary edema and acute respiratory distress will occur. How the hantavirus is transmitted is it is airborne via dust that's contaminated with urine, feces, or saliva of infected rodents. So this is actually due to the fact of rodent populations where they have left either urine or feces or even saliva that has dried and then becomes aerosolized and we breathe it in. Deer mice or other rodents harbor one or more of the multiple strains of hantavirus. Incidence has been increasing in areas of the U.S. west of the Mississippi River. Treatment and prevention, diagnosis through detection of the hantavirus using IgM antibody or PCR techniques has actually been used for diagnosis. And really there's no treatment other than supportive care. So we can see that this has actually been the cases, and this was valid as of 2013, so a little bit dated. But again, most of these are out here in the southwestern United States. Yosemite here in California had to close down a few years ago because of an outbreak of hantavirus. We've not seen any that I know of anyway, hantavirus in Missouri as of yet. I would have to check and make sure with the CDC, but I'm not sure that we've seen any here in Missouri yet, but don't hold me to that. So in chapter 21, this just shows again some information about the hantavirus. So, summing up, microorganisms that cause disease in the respiratory tract out of chapter 21. So again, if you want to learn more about these diseases, these page numbers are going to be very close. And that's disease 2. So we'll finish up the diseases in disease 3 in the PowerPoint. See you then.